Today I'm going to talk about another very important topic, acute vomiting. This is part 1 of acute vomiting. And this part will emphasize on how to approach a patient with vomiting, what to look for as an emergency physician, how to identify the life-threatening problems, and to look for and to treat them accordingly and adequately and quickly. It's a very, very important. Vomiting is associated with many of the life-threatening injuries. We'll talk about diseases in detail in the next lecture, but for now, how to approach a patient with acute vomiting. So, first, before even going to obtain a vital sign, I have been telling you again and again in every of my lecture that first you have to make sure airway is intact, breathing is intact, and circulation is intact. So first and the foremost thing you do is apply oxygen. Airway, you maintain the airway if the patient is not maintaining saturations. Airway, then go for breathing. If it's symmetrical or asymmetrical, if patient is getting enough oxygen inside, then go for circulation. So for now, obtain complete vital signs. When you receive a patient with vomiting, we'll talk more about the detail of the history points that you need to ask. Think of life-threatening injuries later on in this coming slides. But for now, when a patient comes to you with vomiting, first and the foremost thing you have to do is blood pressure and heart rate. Why is blood pressure important? Because hypotension is a sign of hypovolemic shock. And if heart rate is increased, that is tachycardic, there is reflex tachycardia because of hypotension. So this patient is in fluid depletion. This patient needs therapy, fluid therapy. So respiratory rate and pulse oximetry. Respiratory rate is important. If it's increased, think of vomiting due to any infective cause of the chest or any MI leading to acute left ventricular failure. So this indicates increased respiratory rate. Pulse oximetry to see oxygen levels. Although pulse oximetry is not highly sensitive, but it gives you an adequate and quick information about the saturation, oxygen saturation inside the human body. Rectal temperature is important at times to see if rectal examination and temperature monitoring is important to see if there is any bleeding from in the rectum coming from upper GI bleed. Moving on to signs of volume depletion and decreased perfusion. Shock, hypotension, and orthostasis. These are the signs of volume depletion. So how do you assess shock? Hypotension, tachycardia, altered mental status, dehydration, signs of dehydration, dry mucus, and orthostasis, where the patient from sitting position stands up, there is increased dizziness, and orthostatic hypotension is a sign of fluid depletion. So if what we have mentioned till now is present, what to do first? Put a large IV bore cannula. Patient needs fluid. Start supplemental oxygen, airway, cardiac monitoring, breathing effort, breathing, and see for circulation, decreased blood pressure, go for a fluid resuscitation. Needs normal saline resuscitation. Draw a complete blood count, electrolytes and kidney and liver function test, lipase, pregnancy test, and cross-match depending on the history. We'll talk more in detail about what you think while talking about the history taking questions. Empiric antibiotics if there is acute appendicitis or pancreatitis, or there is acute cholecystitis as well. GIT decontamination if there is bowel obstruction. If there is bowel obstruction and there is bilious vomiting, and blood products if it's due to upper GI or lower GI bleed. So if the patient is stable enough, there are no signs of volume depletion or hypotension or decreased perfusion, then ask for or look for any focal or severe abdominal pain. If there is focal or severe abdominal pain, think of mesenteric ischemia. Think of acute pancreatitis. Signs of peritoneal inflammation, think of Perforation. Think of acute abdomen, appendicitis that's been perforated. Think of any other cause that might cause peritoneal inflammation as well. Pain that precedes vomiting, and it can be insignificant, and pain that goes away with vomiting is sign of gastric outlet obstruction. So if there are these signs present, think of acute appendicitis, intestinal obstruction, mesenteric ischemia, gastrointestinal bleed, and ectopic pregnancy. If there are no focal signs, there are no signs of peritoneal inflammation or pain that precedes vomiting, think of cholinergics or sympathomimetics. As we'll talk in detail about the aspirin toxicity or acetaminophen toxicity in the next part of this lecture, they mainly present with vomiting and nausea. With multiple medications, evidence of other toxic exposures should be ruled out while taking a careful history. If there are signs of toxidromes, think of seafood ingestion with neurological symptoms. If there are, consider Clostridium botulinum, amnestic shellfish poisoning, pufferfish poisoning, and neurotoxic shellfish poisoning can cause neurological symptoms. If there is no neurological symptoms and there is no history of seafood ingestion, consider antibiotics, chemotherapy agents, laxatives, antacids, antihypertensive, digoxin, theophylline, carbon monoxide. These, and the list goes on, these can cause vomiting again and again. So these are the drugs which have side effects of causing vomiting. But if there is no toxidromes present, there is no multiple medications, there is no evidence of toxic exposures, ask for chest pain, shortness of breath, diaphoresis, cardiac history, evidence of pump failure. Why? Because these are the signs of acute MI. And vomiting is also associated with chest pain in acute MI. So patients with respiratory failure and due to left ventricular failure or right ventricular failure or congestive heart failure, they can present, or new onset chest pain, they can present with signs and symptoms of acute myocardial infarction, which includes nausea and vomiting. So how to approach in those patients? You have to provide this patient an oxygen, you have to check for breathing, you have to check for circulation, and then you have to proceed for anticoagulation, either by aspirin or dispirin or streptokinase, or this patient might need percutaneous stent placement. But if this patient is in failure, you have to go for nitrate infusion, you have to go for diuretics, you have to go for oxygen supply, you have to monitor the output to see what might be the cause of all these symptoms. But again, it started off with vomiting, a simple clinical symptom of vomiting, but the underlying disease is way dangerous and life-threatening, so that needs to be treated adequately as well. So if there is no chest pain, think of trauma, abnormal neurological examination, altered mental status, think of any intracranial pathology. If there is physical or historical evidence of endocrine emergencies or pathology that can cause vomiting as well, rule out that endocrine pathology and treat, which includes thyroid storm or hypocalcemic crisis, where these include these can cause vomiting and other associated symptoms. If there are signs and symptoms of all these mentioned above, which include chest pain, trauma, or any abnormal neurological signs, altered mental status, or any endocrine disease, history of endocrine disease, consider a cardiologist opinion, cardiac markers, and things related to cardiology. Central nervous system, get a CT scan, lumbar puncture, or MRI if required. Endocrine, get an opinion from endocrinologist. But if there are no signs of chest pain, trauma, or historic or endocrine pathology, think of any additional information, any recent travel, foodborne, community outbreaks, or hospitalization. These can all cause outbreaks of vomiting, or simple viral gastroenteritis can cause vomiting as well. So, if the patient is toxic appearance, systemic systems, fever is more than 39, Altered vital signs, which includes tachycardia, hypertension, decreased pulse oximetry saturations, abdominal pain, or bloody diarrhea, dehydration, myalgia or cephalgia, if there is present, if the patient is elderly or infant. Look for two extremes. If infant or elderly, complicated medical conditions or immunocompromised, this patient needs hospitalization, supportive care, blood cultures, stool cultures, and empiric antibiotics. So let's review again. If the patient is having an abnormal vital signs and is an elderly or infant within two extremes and have multiple comorbids, immunocompromised, this patient needs admission and empirical antibiotics. If there is no signs of toxic appearance or shock or any other altered vital signs, this patient could be given a trial of per oral or IV hydration. Empiric antibiotics, ciprofloxacin, could be given 500 milligram for 7 days. Stool cultures and ova and parasite cultures, and decision should be made on admission versus discharge home. But if additional information required, traveling to developing countries, for example, in countries where HIV is endemic, immunocompromised, or patients or having a prolonged stay in society where there are patients of HIV, considered evaluation and treatment for amoebic dysentery. History of any recent antibiotic use, consider Clostridium difficile colitis. Before moving on to further history questions and what questions you need to ask in a patient with vomiting, I would like to spend some time to get you an idea or brief you about the red flags of vomiting. Red flags of vomiting includes hematemesis, which suggests upper GI bleed, miliary waste tears, epigastric bleeding source from an esophagus. Then, is there any sudden suicidal thoughts? Patients with overdose, drug toxicity, patients with headache, papilledema, signs of meningeal irritation can present with vomiting. Think of meningitis, think of meningoencephalitis, think of increased intracranial pressure, think of hydrocephalus, think of ischemic stroke or a hemorrhagic stroke. If there is any previous abdominal surgeries and a patient have a history of a constipation, think of constipation due to adhesions, that is post-surgical complications. Elderly population is at high risk, is a red flag sign too for persistent vomiting, because these patients needs an extensive workup. For example, they are susceptible for ischemic stroke, they're susceptible for cardiovascular accidents as well. Bilious vomiting in child, think of gastrovalvular problems, volvulus. Projectile vomiting in infant, think of pyloric stenosis. Any signs of alcohol abuse, think of any signs of recurrent infections, DKA, diabetic ketoacidosis. These are the signs. These are red flag signs too, and they are high yield because you need to first look into emergencies related to these risk factors or red flags that you need to address first. Then you should proceed for any other problem that might cause these symptoms. So moving on to history. First question you need to ask, what was in your vomit? Was it food? Was it blood? Was it mucus? Why? Because if it's food, it might be due to some other causes. There might be due to some gastroenteritis, acute myocardial infarction. There might be some other causes. If there is a blood, that should be a concern for you. Because if it's a clotted blood, think of prolonged bleeding. If this is a fresh blood, think of an esophageal source. But what to do in these patients? If it's a blood in it, hematemesis, if it's a blood in it, even patient have a history of any hematemesis in the past, or the patient have a history of hepatitis C related decompensated liver diseases, or liver cirrhosis, or portal hypertension, esophageal varices, miliary waste tears. The first you have to do is you have to resuscitate this patient. Even if patient is, first you have to take on this on vital signs, check for any signs of hypotension, hypovolemic shock, look for any hypovolemic shock or hemorrhagic shock, treat first, then you go out to find the cause and or treat some other thing. If there is mucus at times where there is increased coughing, there turns out to be an increased production of the mucus, where at times it's misconfused as a vomitus, but it's called the phlegm. Cough and bleeding with abnormal vital signs should be treated adequately and timely and as soon as possible. So, moving on to, was there anything that preceded or is associated with vomiting? A vomitus with cough is called postusive cough, postusive vomiting. That is associated with, that is due to cough. At times, there is increased mucus production, that's called phlegm, but it's sometimes misdiagnosed as a vomitus. Was there any preceding abdominal pain with vomitus? If there is, that at times is non-significant. But if there was a pain that has been relieved with vomitus, that is due to gastric outlet obstruction. How many times did you vomit? Why is this question so much important? Because if a patient has been vomiting, or even a patient is of hematemesis and has been vomiting blood out of multiple episodes, this patient is at high risk or impending hypovolemic shock. This patient will go into hypovolemic shock or hemorrhagic shock due to blood loss. So, multiple episodes should, how many times, a rough estimate would give you an idea. But if a patient couldn't tell you, vital signs would tell you something about the hydration status. But you have to ask if the patient is, apart from if the patient isn't having hematemesis and is still, or otherwise vomiting fluid, is also a sign of dehydration, and this patient should be taken care of as soon as possible. When did the vomiting occur? Because in patients who are pregnant and patients who are uremic, they tend to occur, they have increased episodes of nausea and vomiting in the morning. With patients with increased intracranial pressure, they tend to have vomiting more with position of the head, right? Patients with acute pancreatitis, they tend to have increased vomitus while lying down. So these are the signs. These are when vomiting increases at a specific time at what vomiting occur, especially in females and uremic patients and increased intracranial pressure patients. How long have you been vomiting? For how many days? If it's acute, if it's less than 1 week. More than 1 week, it's chronic. If it's acute, there might be multiple causes of it. For example, there is due to infection, obstructive cause, infective cause, metabolic cause, electrolyte cause. If there's chronic, there are some other causes, for example, tumor, surgical mass, and most of the things that are related with chronic diseases can cause chronic vomiting as well. With acute vomiting, you can have in patients with renal colic as well, patients with testicular torsion as well. Patients with ovarian torsion can present with acute vomiting, that is vomiting from the past less than 1 week. Have you been able to tolerate fluids between the vomiting episodes? This is a very, very important question, and it is as a question you need to ask every person who presents with vomiting before sending them home. If they answer it yes, they can tolerate, you are safe to send this patient home. But if they are not and still you send it, that's negligence. So if a patient tells you I can orally take it, you give an oral rehydration trial. We have that's called as oral rehydration challenge. If the patient can tolerate orally, the patient can be sent home. But if the patient cannot take orally, despite antiemetics, intravenous antiemetics, this patient needs admission. So moving on to physical examination. Physical examination is very, very important in patients with vomiting and patients who are suspecting to be dehydrated or patients who are in a hypovolemic shock. So how do they present? General appearance is dull, toxic looking, pale looking, this would give you an idea this patient is dehydrated, this patient is volume depleted. So what else you can do? You can check for any sunkening of eyes, any fontanelle problems, any source of bilious vomiting that you could see on the face, or any clothes. This you can see in general appearance. This would give you an idea that this patient might be having this kind of, if this is bilious vomiting, you should suspect this kind of disease that this patient is going through. Vital signs, I repeat again: blood pressure, heart rate, temperature, oxygen saturations, and temperature, and respiratory rate is very, very important to know in these patients. Why? Because this set of vital signs would give you an idea if this patient needs aggressive treatment or this patient needs an aggressive history or a physical examination. Moving on to pulmonary. Pulmonary can cause vomiting because of recurrent infections, or pneumonia at times can cause vomiting. So on physical examination, chest auscultation, you might find a rhonchi or wheeze, or audible wheeze in patients with asthma, or patients with acute myocardial infarction can present with left ventricular failure, and thus can present with rales and bilateral crepitations on chest auscultation. So these are the physical examination findings you would see and appreciate while doing a pulmonary examination. Neurological examination, to look for any focal deficit, papilledema, increased intracranial pressure, any focal neurology, signs of cerebellar infarction, for example, if there is any nystagmus, vertical nystagmus, positive past pointing, inability to walk, sway on an ipsilateral side. These are the signs and symptoms of posterior cerebellar stroke, which present with vertigo and dizziness, and at times present with vomiting. Any signs of increased intracranial pressure that can cause vomiting as well should be examined in focal neurology. Otherwise, look for pupils. If there are unequal, think of intracranial hemorrhage or intracranial bleed, or any intracranial pathology that is causing the vomiting as well. Abdomen, it is the most important system to examine in a patient with vomiting. You have to look for any, on inspection, you have to look for any peristaltic, abnormal peristaltic movements. For example, in kids with pyloric stenosis, they have a peristaltic valve around the stomach showing the pyloric stenosis. Otherwise, in elderly males, look for any signs of any previous surgical scar, which might lead to adhesions and leading to any constipation, which leads to vomiting. Look for any auscultate for any audible bowel sounds. If they are hyper exaggerated, think of constipation, which might lead to vomiting. If they are sluggish, think of constipation, which might lead to vomiting as well. Abdominal examinations include epigastric tenderness. Look for epigastric tenderness. If there is any, think of acute pancreatitis and acute cholecystitis. Right upper colon pain with Murphy's sign positive. Think of acute cholecystitis, acute cholelithiasis. Moreover, with right iliac fossa pain and rebound tenderness, or patients with rosing signs, that is characteristic of acute appendicitis. In simple words, you palpate the left iliac fossa, and if the patient is feeling the pain in the right iliac fossa, this is an appendicitis, acute appendicitis. So these are the signs and symptoms. These are the things you need to look for in patients while examining examine the abdomen in patients coming to you with vomiting. With genital, you need to look for testicular torsion, scrotal pain, ovarian torsion. Look for any renal colic. Look for any renal colic. Look for any signs of hematuria. Look for any signs of urinary tract infections. Recurrent testicular torsion can present with vomiting as well. A torsion of the appendages can lead to nausea and vomiting as well. Extremity, look for distal pulses. If there are a feeble pulse, look for the sign of hypertension. This patient needs urgent and adequate fluid resuscitation. Skin, cold, clammy, hypovolemic shock. If patient is not maintaining enough blood pressure due to dehydration, these are the physical examination things you need to do in a patient when they present up with vomiting. Moving on to associated symptoms with vomiting: gastrointestinal, for example, abdominal pain, diarrhea, and constipation. As I mentioned before in the previous slide, abdominal pain is constant in patients with acute cholecystitis, acute pancreatitis, and right iliac fossa pain, while diarrhea and vomiting is most commonly seen in acute gastroenteritis. Acute gastroenteritis can be viral or bacterial, and all you need to do, if it's not life-threatening, to do is fluid resuscitation, and this patient could be sent home. With constipation, especially in elderly with a history of previous surgery or adhesions, can present with constipation. Volvulus or intussusception can present with constipation. These are the signs and symptoms, associated symptoms you would see in a patient with vomiting. Neurological associated symptoms associated with vomiting: headache, for example, worst headache of life, subarachnoid hemorrhage. Think of subarachnoid hemorrhage patients with hypertension. Think of intracranial bleed. These headache will present a migraine. Headache present with nausea and vomiting as well. So these are the neurological symptoms you would appreciate in a patient with presenting with vomiting. Altered, increased vertigo and dizziness, spinning of the head, spinning of the things around surroundings. For example, in patients with benign positional vertigo can present with nausea and vomiting as well. Dizziness, again, signs of posterior circulation and fog, signs of benign positional vertigo. Subarachnoid hemorrhage, worst headache of life, intracranial bleed. These can cause vomiting, change in pupillary structures, signs of focal neurology, irrelevant behavior, or altered mental status. But vomiting is also a common presentation with neurological problems. Tumor: is there any space-occupying lesion inside the brain which is compressing or activating the chemoreceptor trigger zone inside the brain, leading to vomiting as well. Infections, meningitis, meningoencephalitis, they all can lead to vomiting in those patients. Genitourinary, kidney stones, renal colic can present with nausea and vomiting. Testicular torsion can present with nausea and vomiting. These are the high-yield emergencies, and these have been covered in detail under the section of genitourinary emergencies. Inguinal hernia, or for example, strangulated inguinal hernia, can at times present with signs and symptoms of vomiting. Testicular pain, and as compared to testicular torsion, simple testicular pain or epididymitis, or appendages, torsion of the appendages, can present with signs and symptoms of vomiting. Back pain, the costovertebral and tenderness, back pain, these can present with nausea and vomiting. Renal colic, vaginal bleeding can present with vomiting. Sexually transmitted infections, pyelonephritis can present with vomiting. Pelvic inflammatory diseases can present with vomiting. Ovarian torsion can present with vomiting as well. Ectopic pregnancy can present with vomiting as well. Why is ectopic pregnancy would be my highlight point in this slide? Why? Because when you receive a patient with epigastric pain, with abdominal pain, with even a history of previous dates or knowledge of previous last menstrual cycle, or without, even they are married or unmarried, you have to look for, if abdominal pain, look for beta HCG, and further you have to move on for ultrasound if beta HCG is positive. First and foremost thing you have to rule out is ectopic pregnancy, and you have to take a gynae and obs on board to treat ectopic pregnancy. So moving on to cardiopulmonary systems. Cardiopulmonary symptoms are very, very important and very high yield and life-threatening if not treated adequately. So when you receive a patient with vomiting, chest pain, sweating, or profuse nausea, think of an acute MI. So, chest pain. This is a very, very common complaint. It can be a musculoskeletal, but a patient with a history of diabetes, hypertension, family history of ischemic heart disease, think of an acute MI. But how do the patient present? They present typical chest pain that is central in nature, central in location, radiation to the left arm with profuse sweating and vomiting. At times, especially in patients who are diabetic patients, they won't appreciate the chest pain because of the neuropathy that they're going through. So what happens is they start off with nausea and vomiting. And at times, they just misdiagnose it as simple a gastritis or acute gastroenteritis, but on the other hand, it's acute MI. So when you receive a patient with diabetes or multiple risk factors presenting to you with chest pain, nausea, and vomiting, get an ECG first. Because ECG is very high yield. It won't take much of your time, but would give you a lot of information. And eventually you could save this patient's life. So when you receive a patient with chest pain and you're suspecting myocardial infarction, how would you proceed then? You have to look for an anticoagulation therapy. You get an ECG if it's an NSTEMI, ST elevation MI, or non-ST elevation MI. If it's ST elevation MI and if it's in the window period, that patient should be transferred to cath lab for angioplasty. But if the patient is late, you can go for a streptokinase injection, but at least this patient needs anticoagulation. On the other hand, chest pain is common in patients with chronic cough. For example, in patients with chronic obstructive pulmonary diseases, patients with pneumonia can present with vomiting as well. The patients who are with chronic bronchitis or productive cough, patient with tuberculosis, they tend to have increased chest pain, and with chest pain there is increased chances of vomiting. That is called post-tussive vomiting. So patients, you need to identify if the vomiting is gastrointestinal or something else related to it, or if it's pulmonary in origin as well. Moving on to fever, as I mentioned, now, patient with recurrent pneumonia, a patient with pneumonia or fever or chest pain or pericarditis, they can present with signs and symptoms of vomiting. They will present with vomiting. Patients with acute febrile illness, pericarditis, they can present with vomiting as well. So you have to identify what is the cause of vomiting in these patients. Moving on to pneumonia, as I said, lower respiratory tract infections, upper respiratory tract infections, tonsils, enlarged tonsils could produce vomiting because it's hard for you to engulf the food that you take in. So it's hard for you and the patient tends to vomit out. So these are the diseases when they are readily associated with vomiting. Myocardial infarction, as I explained again, first and the foremost thing, patient present with chest pain, nausea, and vomiting, get an ECG first, then move on to some other diseases, think of some other diseases. Exclude the life-threatening injuries first. Cough, as I mentioned, in lower respiratory tract infections, patients with upper respiratory tract infections, patients with recurrent pneumonia, patients with cold working pneumoconiasis, patients with environmental exposure, cough can have a vomiting as well. So you have to be clear of what might be the cause. You have to exclude what are the life-threatening causes which associate or which include vomiting as a symptom. You have to exclude them first, then you have to treat the other problems that are not life-threatening or can be managed lately as well. Moving on to some diagnostic testing required in patients presenting with vomiting. Again, what to look for in patients with vomiting: is there any dehydration, life-threatening injuries? Exclude them, then move on to some non-life-threatening problems. So bedside glucose level is very, very important. Why? Patients presenting with vomiting can have diabetic ketoacidosis. So in diabetic ketoacidosis, the primary symptom, the predominant symptom is vomiting. Patients tend to have an aggressive vomiting. In acute pancreatitis, patients tend to have vomiting. In acute cholecystitis, patients tend to have vomiting. Subarachnoid hemorrhage, intracranial bleed, they all tend to have vomiting. Patient present with ultramental status, first and foremost thing, check blood glucose level. With blood glucose level, rule out diabetic ketoacidosis. If there are hyperglycemia, if there is ultramental status, first thing you have to do, rule out hypoglycemia. Complete blood count, signs of infections. For example, increased white cell count in acute appendicitis, acute white cell count in acute cholecystitis, acute pancreatitis, decreased hemoglobin in patients presenting with upper GI bleed, hematemesis. Hematemesis can present with increased blood loss and eventually decreased hemoglobin levels. Decreased platelets can lead to increased bleeding chances in patients with upper GI bleed or hematemesis. So these are very important indicators that you need to know in complete blood count to rule out any problem that might cause these lab investigations. Electrolyte testing, you have to rule out any electrolyte abnormalities that are causing vomiting. Hyponatremia can cause vomiting, hypokalemia can cause vomiting, hypomagnesemia can cause vomiting as well. So these electrolyte abnormalities should be ruled out to see if there is any electrolyte imbalance leading to vomiting. Liver function test in patients with right upper hypochondrial pain, in patients with cholecystitis, in patients with pancreatitis, in patients with cholelithiasis or choledocholithiasis that can cause vomiting or can cause vomiting in this patient, or recurrent cholecystitis, cholelithiasis can present with vomiting as well. So this patient needs liver function test to rule out any liver pathology going on inside. Troponin test, cardiac markers are very, very important and a high yield in patients with acute MI. Cardiac markers are typically raised, especially troponin I, is typically raised within 4 hours after the onset of chest pain, but it is recommended to have a baseline of troponin T or troponin I, and then repeat troponin I after 4 hours of the onset of the symptoms. So these blood tests are very important in knowing the patient's troponin I is very, very sensitive to cardiac MI. Pregnancy test, especially in patients with ectopic pregnancy, beta-HCG levels are raising. Think of ectopic pregnancy with abdominal pain and vomiting. Vomiting is normal in patients with first trimester pregnancy. So they have to rule pregnancy should be ruled out first. Urine analysis in patients with renal colic, patients with hematuria and blood and urine. First, there should be a urine analysis should be done to rule out if there is any hematuria. If there is hematuria, this patient is suspicion of renal colic. You have to go for a helical CT scan, uncontrasted helical CT scan to rule out any renal colic. Moving on to ECG, as I mentioned before, it's high yield in patients with suspicion of acute MI. Get an ECG first, and we give you a lot of information. So within it is recommended to proceed for an ECG within 10 minutes of the arrival of the patient. So this can save time and protect you from fatal outcomes. Radiological studies, chest X-ray to rule out any pleural effusion, pulmonary edema, any pneumonic patch or signs of lower respiratory tract infections. Next, radiological studies, which includes ultrasound, which is more commonly used in patients with biliary tract diseases. For example, patients with cholelithiasis, cholecystitis, Also, in pregnant females with suspicion of renal colic, ultrasound is the diagnostic of choice because they have to be protected from the radiations of a CT scan. Ultrasound, also color flow Doppler ultrasound, is also a diagnostic of testicular torsion and ovarian torsion, which shows decreased blood flow to the affected testes. So ultrasound has the highest modality in patients with right hypogonadal biliary tract diseases, acute pancreatitis, and at times can detect acute appendicitis as well, but CT is the diagnostic of acute appendicitis. Brain CT in patients with subarachnoid hemorrhage, patients with vertigo and dizziness due to posterior cerebellar stroke, patients with acute infarct, cerebellar infarct, patients with intracranial bleed, they all need to go through a CT scan to make sure that what underlying pathology is going on inside the brain. Because as I mentioned before, the sign and symptoms of intracranial bleed versus intracranial ischemia is somewhat the same on presentation. So it is hard for you to identify if this patient is going through a bleed or is this patient having an ischemic stroke. So you have to identify what treatment, how to identify, get a CT scan, and look for any bleed or ischemic stroke or a hypodense area that might show an ischemic stroke. Nasogastric tube is very, very important in patients with constipation to decompress the abdominal distension because that's due to the constipation. So nasogastric tube is also used in patients with upper GI bleed to remove additional to remove the blood to clear the field from the blood so that endoscopist can move in and find the bleeding point and to stop the bleeding. In this lecture, we talked about how to approach a patient with vomiting, what to look for, what signs and symptoms one should look for in treating the life-threatening injuries, the life-threatening problems that, if not treated otherwise, could lead to the death of the patient. So, we did talk about how to approach and what to do in patient and what to think of with certain amount of symptoms that we have. We talked about some of the disease-associated symptoms, which includes neurological, cardiopulmonary, abdominal, genital, and genitourinary problems that are associated with vomiting. We then talked about the lab investigations required, and then we talked about the radiological studies required for specific diseases. That's all for now. Thank you for watching sqadia.com.